News Special Report.
For any further assistance, please press *0. Please be advised that today's conference is being recorded. I would now like to hand the conference over to your speaker today, Michael Schomer. Thank you. Please go ahead.
Thank you for joining us for a special COVID-19 media call for August 25th. We'll start today's call with a quick situation report from Commissioner of Health Jan Malcolm and Infectious Disease Director Chris Eiersman. We'll then get an update from Commissioner Malcolm on today's topic in focus. After these updates, we'll open it up for questions from reporters on the line. With that, I will now turn it over to Commissioner Malcolm.
Thank you, Mike. Good afternoon, everyone, and thanks again for making time for an additional call today. Around the world, as of this morning, we are now above 23.6 million cases and 813,000 deaths. In the United States, as of this morning, we are over 5.7 million cases and over 177,000 deaths. Here in Minnesota, we've reached a new cumulative total of laboratory confirmed cases of 70,707, with an additional 414 laboratory confirmed cases reported yesterday. This lower case volume corresponds to our kind of weekly low testing volume, which is typical of a Tuesday report, which is Monday's results, reflecting lower weekend level of activity. So this 414 cases from yesterday was on a volume of 8,858 tests. The relationship between case growth and test growth remains pretty much the same. Our total increase in cases was 7% week over week from yesterday to the week prior. During that same time period, total tests were increased by 7.8%. The 7-day rolling average test positivity rate was unchanged at 4.9%, with factoring in the 1-week lag. So that test positivity rate is calculated as of August 16th. Unfortunately, we have had an additional 8 deaths in Minnesota reported yesterday, bringing us to 1,779 of our fellow Minnesotans who've lost their lives to COVID-19. 1 each in Ramsey, Hennepin, Sherburne, Nobles, Anoka, Becker, Watonwan, and St. Louis counties. This includes 2 persons in their 80s, 3 in their 70s, and 2 in their 60s. There are currently 312 patients in the hospital, 137 of those in intensive care. This reflects a net increase of 2 additional people in the hospital compared to the prior day, 2 more net in the ICU. As Mike indicated at the beginning of the call, we wanted to schedule an additional call today to talk some more about the announcement, the good news that Governor Walz and Lieutenant Governor Flanagan released this morning about our plans to build a new COVID-19 saliva testing lab in Minnesota. I'm sure many of you have seen that press release from the governor's office this morning, but to recap the highlights, Minnesota has partnered with a company named Vault Health to create plans for a new laboratory in Minnesota. This new lab is good news for our COVID response because it will significantly expand, but also importantly diversify our testing capacity for our state, which is going to help us continue to manage this pandemic and help to slow the spread of COVID-19, as we know that this is going to be with us for some time. This new laboratory will also create some new jobs at a time when we certainly all recognize the importance of that, given the economic challenges that so many have faced. The state is just now in the process of finalizing this contract with 2 companies to do this. This is Rutgers University's RUCDR Infinite Biologics, that holds the country's first FDA emergency use authorization for PCR saliva tests, and Vault Health, which provides all the logistics and all of the supporting services and telehealth services necessary to carry out, operationalize the testing. This planned lab will give us the ability to more than double the state's current test processing capacity. Right now, we have built up the capacity to do around 22,000 tests each day, thanks to the partnership with our state's health systems, Mayo Clinic, and the University of Minnesota. We've come a really long way in building up our testing system and our capacity in Minnesota thanks to that partnership. And in addition, we know it's important to continue growing and diversifying that capacity to test as we enter the next phases of the pandemic. This added testing capacity will allow us to do a number of important things. It will allow us to offer more testing for more priority groups, including people who have had close contact with someone who tests positive for COVID-19. It will allow us to do more community testing in underserved populations. It will allow us to do rapid focused testing as a part of trying to control outbreaks when they occur. And very importantly, we believe it will help us with enhanced testing to prevent further growth in cases through more surveillance testing and more targeted testing in populations that we are particularly concerned about being at risk. And with schools set to resume soon, we also know we'll need significantly more testing capacity to support schools. We absolutely expect to see an increase in respiratory illnesses when school resumes. That is an annual fact of life. And it's going to be important to be able to quickly distinguish common colds and other typical seasonal illnesses from COVID-19. So when a child has a runny nose and a fever, their parents need to be able to quickly get them tested to know whether it's COVID-19 or not, so they know whether they need to isolate for 14 days. We also know that colleges and higher education institutions and many employers are working on their own testing regimens and may need to be able to tap into more testing capacity than currently exists in our state. Having more and more diverse testing options is an important tool. It's a great step forward for our overall COVID strategy. Under this plan, a new saliva lab will be located in Oakdale, Minnesota. This lab will be capable of processing as many as 30,000 samples per day if it runs really full-time at 3 shifts each day. That would take our total statewide testing capacity to more than 50,000 tests each day. But just as important as growing our capacity is diversifying that capacity. It's been a consistent piece of our strategy in Minnesota heretofore, and it's something that follows increasingly urgent federal guidance to keep on diversifying testing as global supply chains will continue to be under some stress. If there are shortages for specific supplies, specific types of reagents, for example, or for swabs, this saliva lab gives us other options. This saliva test reduces the need for swabs, viral transport media, and personal protective equipment. It also uses different laboratory instrumentation than that used by most of our health systems. So the more diversity we have in our testing system, the more resilient we can be, and the less prone to having capacity constraints in some of the lab suppliers really constrain our capacity to test in Minnesota. We know that everyone's working as hard as they can to manage the global supply chain, but there's just a reality to how much pressure there is on that system. So the more diversified we are, the better able we are to manage through those periodic supply chain issues. This new laboratory, this new saliva testing capacity also will be an important augmentation and frankly a sort of a pressure release valve for the testing system that we've built heretofore. It will augment, not replace, but augment the capacity that our clinics and health systems have built up. Many of these clinic and health systems are needing to manage their supply and testing capacity so that they are able to meet their urgent clinical needs first. Perhaps for hospitalized patients, patients undergoing procedures, people in the ICU, essential personnel, emergency rooms would need to be highly prioritized for testing first, as well as healthcare workers, for example. So that's been an issue for people seeking testing within their health systems when they have only mild symptoms or no symptoms or have been exposed to others. So this saliva-based system will augment that capacity and make it more possible for people not meeting some of those more narrow and appropriate, I will say, clinical priorities to get tested and get tested quickly with this new methodology. So how this works for Minnesotans, people will be able to eventually, not immediately, but eventually able to access a saliva test in several different ways, 3 ways. First of all, we plan to set up 10 semi-permanent collection sites around the state. And any person will be able to come to these states located geographically around the state to get the saliva test. Second, the state and other partners will offer the test at mobile testing events, much as we've been doing. Fortunately, the saliva test requires much less personal protective equipment than a traditional nasal swab for COVID-19 because it is self-collected under the supervision, but not the hands-on administration of a health professional. Third, Vault Health also provides logistics and telehealth services to enable people to collect the sample at home. We have not yet defined the parameters for this mail order testing program, but that will be a feature of access in the future. This home-based system generally works like this. A person receives a testing kit via UPS. They spit into a funnel, which is attached to a small test tube. And once enough saliva is collected, the tube is closed with a plug, which then releases a preservative into the sample. This preservative keeps the sample good for up to 2 weeks without needing refrigeration, which is key. Then the person sends their sample back to the lab via a prepaid UPS package and can expect to get results via email within 48 hours or so. So our hope is to have these contracts completed and all the setup will proceed quickly. Our hope is to have the lab up and running by early October. We're really excited about this partnership, our ability to augment this testing capacity that is so important that we already have, and to expand that capacity to make testing more accessible to all Minnesotans. I do want to just remind everyone once again that testing is such a critical part of our strategy in that it provides the information we absolutely must have about who has COVID and when they have it. But testing alone does not suppress COVID-19. It's one critical part of the strategy, which also must include people observing social distancing, avoiding close extended gatherings, wearing masks, washing hands, isolating when ill. These are many of the messages that you hear from us every day, and we just can't stress enough how important testing is in the context of the broader strategy that we all need to be a part of in order to manage this pandemic. With that, I'll turn it back to Mike and open it up for your questions. Or actually,
thank you.
I think perhaps, are we going to pass it off to Chris for some further comments, Mike?
Sure, we can have Chris provide her updates at this point.
Let's do that. Thank you.
Thank you, Commissioner. I was just going to provide one update today, and that was I thought that there would be general interest in the latest number of cases related to the Sturgis Motorcycle Rally. So as of today, we are at 35 cases, an increase of 8 from yesterday. We have 2 employees/volunteers. As we said, one was a temporary employee of a bar. Another case performed in a band. So 2 employee volunteers, 33 attendees, and the 35 cases represent 34 households. We do have 2 cases in 1 household. And I believe, as I mentioned yesterday, the individual who was hospitalized has been released, and we have not been made aware of any additional hospitalizations. And with that, I'll turn it back to Mike.
Thanks, Chris. Operator, we are ready to take questions.
Thank you. As a reminder, to ask a question, you will need to press star 1 on your telephone keypad. And your first question comes from the line of Annie Kelby with WCCO TV. Your line is open.
Hi, thank you for taking my question. I was wanting to ask about the Vikings following the news today about fans not being allowed inside U.S. Bank Stadium during the first 2 home season games. I'm wondering if MDH is working with the Vikings on their plan for fans inside the stadium.
This is Jan. Yes, certainly there's a multi-agency effort to work on guidance and partnering with large venues such as stadiums to understand how the current governor's executive order limiting capacity of gatherings applies in those large settings, and whether, as the pandemic progresses, what are the conditions under which any of those restrictions might be modified. And yes, we do consult with individual venues quite frequently. In terms of the decision on no fans in the stands for the first couple of games, I think as we've been observing that more and more teams are making that decision out of caution and as a measure to have some more time for us to understand the scope of the pandemic as the season begins.
Just a quick follow-up. In your opinion, what would it take for fans to be able to attend games in person again?
Well, the things we always talk about are the degree of community spread, how much virus is circulating in the community, how safe is it for people to be moving about. We know, we'll keep on reinforcing the fact that the virus it is much more transmissible in crowded gatherings where people are crowded together. Certainly a large venue such as the stadium would allow fans to be spread out. You also have to attend to how people get in and out of the stadium, traffic flow inside and so forth. So I think it will be, all the conversations need to turn around how you achieve that critical social distancing and prevent close quarters contact for long periods of time. And it just is with that overlaying kind of concern about the degree of community spread and the amount of virus that's circulating in the community. We'd love to see many, many fewer cases, a much lower test positivity rate, and a much lower rate of community transmission in order for that to just be a safer overall environment for even considering major gatherings.
And Commissioner, can I just add to that as well, just to mention that our priority right now is ensuring that that kids can safely attend school and as many in person as safely possible. And so we want to make sure that what's happening in the community is at a place to allow for as much in-person education as can safely happen. And so that's another consideration in all the conversations.
Thank you.
Your next question comes from the line of Catherine Richer with Minnesota Public RA. Go ahead, please.
Sure. Staying on the sports topic, actually, the St. Paul Saints have had games at CHS Field already. Have you seen any COVID cases connected with those games?
I would defer that question to Chris, but the Saints is a good example of what we were just talking about the ways in which venues are working to figure out how they can apply the current health guidance and the current limitations in the governor's existing executive orders about crowd size, spacing, and so the Saints are a great example of having worked real hard to put in place a plan that complies with those requirements. But in terms of cases, I'll defer that to Chris.
Yep, I'm not aware of cases associated with the Saints.
Okay. And my second question is back on testing. We've talked a lot about some of the shortages you guys have observed in recent weeks around the nasal swab testing process. Are you still seeing some of those shortages? Have they let up a little bit? We keep getting notes from people around the state just saying, I've waited 7 days to get my test results. I'm just wondering if you could fill us in on what you've observed on that front recently.
I'll start, but Chris, please chime in too. We do continue to hear daily reports from health systems, for example, saying that their supplies are such that they, again, as talked about earlier, need to reserve their capacity for high priority clinical needs. And the long turnaround times that have been created, especially by some of the national laboratories, is just another really important reason why we are excited to have more local in-state capacity to turn around tests more quickly. Chris, can you say anything more about turnaround times or anything else from your vantage point?
Yep, I mean, we still are hearing that people are, it's taking a while for them to get their results back, and that can be frustrating. It's not at the same level that it was a few weeks ago, But yes, still some challenges in the amount of time it takes to hear your test results.
And one thing I've always been a little confused on is when you say you're hearing about slow turnaround times, are we talking about samples that are sent to a totally different state and getting processed there? Or are we talking about samples that are being processed at Mayo's labs or sort of, within the Minnesota ecosystem?
Yeah, great question, Catherine. I was just going to say the problem has been the most exacerbated with the national laboratories that are in other states that are getting huge volumes from all around the country. Some of our clinics and health systems have contracts with those national reference labs. Test turnaround time at Mayo has been stressed because of the same thing, the volume of tests coming into them from all over. But I think our Minnesota labs have generally maintained a much better turnaround time than the national laboratories. But I'll defer to Chris too for any more specifics.
Nope, that's just what I was going to say. So.
Okay. All right. Great. Thank you.
Next question comes from Bill Werner with Minnesota News. Your line is open.
Hi, Commissioner. I'm wondering, or maybe this is one for Chris possibly, regarding Sturgis. You folks had been recommending, I think maybe a call or two ago, that people self-quarantine for 14 days. Are we past the point of effectiveness? Is the horse out of the barn in terms of Sturgis and any possible community spread as a result of that if people do not self-isolate?
I'll leave that one for Chris.
Okay. What we're recommending is that individuals would consider self-isolating from 14 days from when they returned. So if they returned from Sturgis, 14 days ago, which I think is perhaps sooner than it ended, but, yes, certainly then that time frame would be over. But we're still encouraging people to self-isolate if it has been less than 14 days from when they may have been visiting Sturgis.
Are you anticipating a further increase in cases, or are we kind of to the end of that wave, do you think? Do you have any way of knowing? Talking about Sturgis cases specifically now.
Yeah, no. I think that we'll continue to see cases, and right now what we are reporting on are cases that had direct exposure to Sturgis, but we're likely to see additional cases with secondary transmission, meaning I traveled to Sturgis, I developed COVID, and now I have exposed and infected someone else. So we anticipate that we'll likely see more cases from people who traveled to Sturgis, and then we'll also likely see additional cases that are associated with that event.
Thank you very much.
Next question comes from Chris Megan from Pioneer Crest. Your line is open.
Hi, I wanted to ask again about screening before testing. I know that the priority is on people with symptoms and has been in Minnesota for some time, but I'm hearing from several of the larger providers that they're almost always requiring at least a video consultation before someone can get tested for COVID-19. What does that do to the chances that someone will actually get tested? And are you worried about that requirement headed into the school year starting up and needing to do more testing in general?
I think it's another great example of the value of adding to our capacity, because yes, some of the health systems have needed to put, rather than being able to liberalize how many tests they can do or what populations they can help to test, they've needed to conserve their capacity to do the highest priority clinical needs, which has led to some of what you just indicated. So it's just another good point for what the value is of having additional testing methodologies available to support testing for people who maybe don't have symptoms but have had a known exposure or who have very mild symptoms, because we are interested in getting as many people who should be tested as possible. And there's still are reasons to be tested and reasons why testing wouldn't be recommended. But there's a whole lot more people we'd like to see getting tested than have been able to so far. Anything to add, Chris?
No, I think you said that well. And well, you know, the one thing I will add is that we don't want people to be, you know, discouraged from testing because of the need for a video visit. If you think that, you know, you have concerns, if you've been exposed, it's worth having the conversation with the provider.
So to follow up on that, and this, Commissioner Malcolm, and this test that you're announcing today, why are you confident that this one is more accurate than some of the ones that officials at the health department here in Minnesota have expressed some skepticism about in the past? I know we've had mail-in testing and saliva tests have been being used across the country now for a while. What makes this one unique or more accurate?
Thanks. That's a great question, because accuracy of tests, sensitivity, and specificity to picking up this particular virus is really important. And I'll ask Chris to add to this too. She knows the literature and the science of it much better than I. But yes, you're correct. There are a lot of tests out there, and they vary pretty widely in terms of their track record for accuracy and specificity and sensitivity. This one has very high ratings. It's the first to get emergency use authorization. And this Rutgers Vault partnership has been doing quite a lot of testing, high volumes of testing, and has a lot of data of their own, which attest to their the accuracy of the test. So, Chris, anything more you can say?
Yeah, I'll just comment on, you know, when we talk about the testing, we've also talked about, you know, what specimens are used. And obviously what's different about this is the fact that saliva is the specimen as opposed to using a swab to collect a sample from the nasopharynx or, you know, just inside the nose. And so studies that have looked at this have found that there's really good agreement between using the NP as a source of the specimen and saliva. And in fact, some studies have said the nasopharyngeal specimen is typically sort of the gold standard for testing for respiratory illness. But some studies have found that saliva is better. Some have found that NP is better when it comes to COVID. But the bottom line is that there's really good agreement between, you know, both types of tests. So the saliva test is a good test. It can be used with confidence, and I think one of the benefits, and I don't know that the commissioner mentioned this, but not only does it not require swabs, which you know, if you ever are thinking about supply chain and logistics, that's one less thing you have to worry about, but also it's a little bit more comfortable than, you know, getting that swab for the test. And so it's just a matter of spitting. Now, I will acknowledge that as the state was looking into this, there were several of us who participated in a bit of a pilot and actually went through the process to do the testing. And it was, you know, it actually went really, really well. But it does take a fair amount of saliva. So with any of these tests, I mean, I think it's important to consider that there's no, nothing is easy, but this is a really good, solid test and has, you know, good results when it's compared to some of the other gold standard tests. So we feel good about using it.
Thanks to you both.
Next question comes from the line of Chris Novak with Star Tribune. Your line is open.
Hi, thanks so much. So I did hear from one testing expert who suggested there was some degree of trade-off with this method, that it's maybe not as sensitive as nasopharyngeal swabs, but you trade sort of that for convenience of collection. Do you think there's a degree of trade-off or not really? It didn't sound like it from what you just said.
Well, if you look at the percent positive agreement, this is looking at a study that had, you know, 350 individuals comparison samples, the percent positive agreement between the nasopharyngeal swab and saliva was 93.8%, and the negative percent agreements, in other words, if you're positive, what was the percent agreement? If you're negative, the negative percent agreement was 99.6%. So, I mean, yes, it's not 100%, and it's not perfect, but yes, you gain the benefit of ease of testing. It's mobile. People can do it. I did it at home on a video Zoom call with someone watching me. So it frees up the healthcare system. So there are a number of benefits to this, but the trade-off is pretty small. So in other words, I think when people talk about a trade-off, the public might think, oh, well, if we do this particular NP test, it's 100%, and if we do the trade-off test, it's 70%. And I just want to be clear that we're looking at a much narrower and stronger agreement between the methods.
Gotcha.
This is Jana. I'll just add real quickly. I think we've talked to and agree with clinicians and researchers who say it will be important to figure out what is the best test for what purposes. That sticking with the nasopharyngeal swab for certain really clinically important uses is probably going to continue to be the case. So again, it's just a great reason why a diversity of capacity is important. We're not at all suggesting that this saliva testing should replace the all the capacity that's been built up with our partnerships with Mayo and the U and the health systems. We believe with increased demand for testing by a whole bunch of different sources, in schools, employers, being able to do more public health surveillance testing, we're gonna need all the capacity we have plus some, which is why now to us seems to be the right time to increase that capacity. But just again, want to emphasize that it will be important to apply some judgment as to which tests are best for which types of situations.
Yeah, and I'm really glad you said that. That's really an important point to make. So thank you. Glad you added that.
And if I could just follow up sort of on the bigger picture, because in the announcement, there was a reference to suppression, right? Suppressing the virus as opposed to just mitigating the virus, and a number of 63,500 tests a day. And so this gets you closer, I gather, to that number. How far away is 63,500? When might the state get there? And I assume, but I don't know, but I assume that there are other things that go along with that, in particular, like a number of contact tracers, I'm guessing, right? And if that's right, where are you in terms of having sort of the workers to follow up and keep things in check?
Yep, it's a great question, and we certainly appreciate all those different kind of reference points that we get from Harvard School of Public Health and others about kind of benchmarks and goals to strive for. It's just to suggest that you could suppress the virus just through testing, I don't think is what Harvard would suggest either. As you said, it's important that you be able to act on the results of the test, and it's important, especially given what we know about asymptomatic transmission, that the other strategies remain in place as well. Social distancing and minimizing close extended contacts, all those things. So we just can't emphasize enough, the central importance of testing to help shine a light on where we are, but that it needs to be part of this larger containment strategy as well. So, and quite honestly, this is personal opinion only, but I don't think it's really very reasonable to think that you could suppress the virus at a state level, given just, kind of what we know about transmission patterns and how much interaction there is across state lines. People are moving around the country. People are coming back to Minnesota from all kinds of places where there's higher levels of transmission than here, and vice versa. As you know, Minnesota been on a quarantine list for some states that any Minnesotans going to other states are asked to self-quarantine for 14 days because of our high levels of community transmission and rapid case growth. So it's just to make the point again that, that we're kind of really are all in it together as a nation as well. So I only mention this, I realize I'm kind of going on here a bit, but the idea of if we could just hit this magic formula at the state level, all would be well, I think is unfortunately just not the case. But we're certainly interested in getting as close to those levels of capacity for testing. And as you rightly say, case investigation and contact tracing. And we have built up a lot of that capacity. We're staying completely caught up with case investigations as they come in, and building, kind of new partnerships and contracts to be able to surge that workforce up as needed as well.
But I want to add, Chris, that by adding 30,000 tests, I mean, we expect that Minnesotans will continue to social distance, to mask, to do things to help prevent transmission. So hopefully 30,000, adding the capacity of 30,000 tests does not mean that we have 30,000 positives every day. We're hoping that this allows us to identify those cases that may be missed, but that people are following the guidance so that we don't continue to see transmission run rampant.
Gotcha. Thank you.
Operator, we have time for one more question.
Understood. And your last question comes from Maury Glover with Fox 9. Your line is open.
Yes, I just wanted to ask about kind of where these tests will be going and who will get these tests first. Are you expecting that teachers would get these tests, and do you expect that that would help with the schools reopening and as they that rolls out across the state?
Yeah, just to reiterate, there are going to be several kind of delivery methods, if you will, for people to be able to get the tests. These the 10 semi-permanent collection sites that we're going to be setting up around the state, that will be a high priority to get all of those up, so that will provide geographic access to everyone, and we don't foresee necessarily creating a prioritization scheme there. It's our hope that we can take all comers at those sites. We will be doing more of the kind of community-based testing that we've been doing, setting up a testing site for a period of days, or in a certain geographic or racial or ethnic community, with community organizations that serve particular populations that we know have been kind of under-tested in the overall system. And then the home-based test, which again, I just need to stress that we're developing kind of the parameters by which the home-based test would work, but that would be a particular, I think we would hope and expect that teachers, who would certainly be a priority population to be able to support the learning models that the various districts and schools are choosing to operate in, that will be a high priority population to be able to identify cases quickly and contain them quickly to support those strategies. So the teachers and other staff and parents with kids could be able to access testing through all of those methods.
Do you have any idea of the timeline on the home collection option, or when you're hoping to have that kind of up and running?
Yeah, we'll get you a kind of a better forecast of what will be entailed in developing that part of the plan. We just want to make it clear that that doesn't exist tomorrow, but that's certainly a capacity that Vault Health has now, and that's been, they've been running very high volumes of tests through that home-based system already. So it's not building a new system, it's just figuring out sort of the Minnesota parameters for exactly, who could get those tests and how, and should there be kind of prioritization, as your question implied. So we can talk more about that in the coming days.
And lastly, are these tests going to nursing homes? I saw a spreadsheet which looked like some of these tests are being distributed in nursing homes and long-term care facilities, and hopefully that was looking like that would happen in September.
Well, I think that's actually a different type of a test.
Okay.
It's a rapid test that the federal government is distributing directly to long-term care facilities. And we don't actually have a lot of detail on when that's going to happen. We do know that Minnesota facilities are among those who will be getting the test. But it's just to be clear, it's a different it's a different test than this one.
Got it. Okay, thank you very much.
That's all the time we have this afternoon. If you have a question we were not able to get to, please feel free to reach out to our communications office this afternoon. Have a good day, and we'll be planning to get back with you again on Friday. Thank you.
This has been a WDIO News Special Report.